All right, we're going to go ahead and get started. Thank you all for joining us today. I know there's a number of faculty and residents and fellows that are the AAP washing their hands incessantly. I know others are here. Before I start, I actually want to introduce Dr. Kilby Mann, who's in the back. Kilby is joining us as a new faculty member at Children's Colorado. She did her training in pediatrics at Rush in Chicago, and then I had the good fortune of working with her during her PM&R residency at University of Washington when I was at Seattle Children's. She then made her way over to Primary Children's in Salt Lake City and decided that Denver weather and snow was maybe a little bit better, or maybe it's just the faculty that she wanted to join. And so Kilby's joining us literally on Monday was her first day. She's going to be doing a lot of consults and inpatient unit, and then doing some as well. So in a minute, please introduce yourself, and if you have any good suggestions for her, if you have kids, she and her husband Joel and are here, and so any kid activities, they'll go ahead and share with her. So I think folks know me. I'm Susan Apkon. I'm one of the faculty members at Children's Colorado, and I'm going to share today a little bit of a journey. I'm going to tell a story about how things are evolving for the care of kids on our neuromuscular program. It's really an incredible time to be a doctor taking care of kids with neuromuscular conditions. When I say neuromuscular, I'm talking about kids with Duchenne muscular dystrophy, and today I'm going to be focusing on kids with spinal muscular atrophy. I think back to when I started training in 1994, finished my residency in 1999, so just over 20 years ago, and how things have evolved. And I hope to really share with you some of the excitement and also some of the challenges that we face when thinking about these novel treatments. I do actually have to disclose a few things, and it's been an incredible, cool opportunity for me as a rehab physician to participate in clinical trials. It's something that's relatively unique in our world. Most clinical trials in pediatric neuromuscular conditions are run by child neurologists, and there's a couple of us PM&R docs. Craig McDonald is sort of the grandfather of them all, myself and a couple others that have had the good fortune over the last now decade to participate. So you'll see that here on this slide. So I'm going to tell a story, and I'm going to tell a story that has sort of a changing ending. We learned this story, and of course, I'm pediatrics, so the Goldilocks and the Three Bears. I had to refresh my memory a little bit, and so in 2020, I got online, I YouTubed it, and actually got to listen to a story being told to me. But everyone knows the story, right? So the bears go out, Goldilocks shows up, she sits at the kitchen, one porridge is too hot, too cold, and then one's right. She sits down on chairs, one's too big, one's too small, and then she goes into the bedroom, and one bed's too heavy, one bed is too hard, one bed is too soft, and then one's just right. The bears come home, she freaks out, she goes running home, never to come back again. That's the story, beginning, middle, and end. What I'm going to share with you today are a couple of other chapters in the story of kids with spinal muscular atrophy. I'm going to talk about novel treatments, FDA-approved drugs that we have now and we're delivering. I'm going to talk about some of the challenges in delivering those treatments, and there are a lot of them. And then finally, as a rehab physician, I'm going to talk about this changing phenotype. The landscape has changed for these kids, and how as a rehab physician, we have to think about the approach that we're going to take, and it's a different approach. The story has a very different ending, and how we think about that. So this is the story I learned about spinal muscular atrophy. I learned that there are 3 childhood types. While we think about 5, we're going to talk about 3 right now. Type 1, type 2, type 3. Type 1 we refer to as kids who are non-sitters. These are infants who present by 6 months of age profoundly weak. No head control, paucity of movements, areflexic, hypotonic, significant respiratory insufficiency, severe dysphagia, and incredibly sadly, they die by about a year. That's the story that I learned in the 1990s. Kids with type 2, as demonstrated by this young man who I had the privilege of caring for, are kids who we refer to as sitters. So type 1, non-sitters, type 2 are sitters. These are kids who are diagnosed generally after 6 months of age, but before 18 months of age. They sit, but they do not walk. They too have hypotonia, they have weakness, they are either areflexic or hyporeflexic. When you ask them to reach for something, they have a little bit of a tremor. They have, depending on the severity of their type 2, they have some respiratory issues, may have some dysphagia as well. They're wheelchair dependent. One thing that I think you can see in both of these slides also is, well, in the middle slide, the attitude of this young man, and in the top left one of this infant, how bright and alert she is. This is a condition of the motor neurons. This is a peripheral process. It's not a central process. These are kids who are incredibly interactive, normal sensation, yet have profound muscle weakness and hypotonia. And then you have type 3. So we have non-sitters, sitters, and we have walkers. Those are the three classic phenotypes of kids with spinal muscular atrophy. They usually present after 18 months of age because they walk. Now, they usually get picked up because they walk funny. Some get picked up pretty early, usually within the first few years of life. And over the last couple of years, I had the opportunity to meet a 15-year-old who was mountain biking until a year earlier when he started having a harder time keeping up with his peers. Ultimately, after a little bit of a diagnostic dilemma and journey, he was diagnosed with spinal muscular atrophy type 3. So this is a story that I learned that most of the people in this room have learned. But again, the story is changing, and I'm going to highlight that right now. So this is a little boy who was diagnosed prenatally with spinal muscular atrophy. His sister has spinal muscular atrophy type 2, and so the parents knew that they were at risk. He was diagnosed in the era of these novel treatments, and he was, within the first month of life, able to be treated with something called nusinersen or Spinraza. So while he has the genotype of someone who has type 2 SMA, his phenotype is of a normal child. His sister, who also has been treated, but she didn't start treatment until about 3 or 4 years of age. She had previously had the ability to crawl, lost that ability, and has regained that. You have two siblings with the same genotype, but very different phenotypes. You gonna cry? Bye-bye. So spinal muscular atrophy is an autosomal recessive disease. People with spinal muscular atrophy have a homozygous deletion of the SMN1 gene. Fortunately, we have an SMN2 gene. It's kind of a backup copy. The only difference between SMN1 and the SMN2 gene is a single nucleotide change. And that change results in the exclusion of exon 7 of the SMN gene, which then causes a reduction of a full-length protein. So the survivor motor neuron protein is necessary for the viability of the motor neurons. Without it, they die. You then subsequently develop the profound muscle weakness and all the complications associated with SMA. So for those who have SMA, you have these copies, and there is a phenotype-genotype correlation that we know. So the more copies of that backup gene, the SMN2 gene, the stronger you are. So you can see there are actually 5 types of SMA. I kind of talked about the 3 most common, 1, 2, and 3. There is a type 0. Those are infants who are delivered right in the immediate newborn period, have profound weakness. They usually have fractures, severe respiratory distress, and typically die in the nursery and never go home. It's really a lethal condition. And then there's type 4 that many of you may see over the course of your life or you have already seen, and those are adult onset. And you can see those adults or those with type 3 have more copies of the SMN2 gene than those who have type 1 or type 2. I said this is autosomal recessive. The carrier rate is super high. 1 in 40 people carry the trait for SMA. So there's not quite 40 people in this room, but presumably one of the people in this room may be a carrier. It is now part of the newborn screening in the state of Colorado, state of Wyoming, and many other states. It's also now recommended by ACOG. So for women who are pregnant or going to be pregnant, they're also recommending screening for the SMA carrier state. So the story is unfolding, and the story really began to unfold on December 23rd, 2017. December 23rd, 2017. So kind of think about it's around Christmas and all the excitement that kids and families have. And that enthusiasm went crazy, 100-fold enthusiasm, because the FDA chose the 23rd of December to announce the approval of the first novel treatment for treatment of kids and adults with spinal muscular atrophy, and that's called nusinersen, also known as Spinraza. You can bet that families started calling our office immediately after they saw this press release, and the phones never stopped ringing. Families figured that they were going to get this treatment on Christmas Eve, and they were going to celebrate even more. What they didn't realize are, again, our challenges in delivering this treatment. I'm going to get into that, but one of the biggest challenges is it's injected by a lumbar puncture, so not the easiest to arrange at the drop of a hat. So let's talk about nusinersen and how it works. Nusinersen is an ASO, an antisense oligonucleotide, which is basically a synthetic piece of DNA that modifies the pre-mRNA splicing. So this is a splice site mutation problem, and so it modifies it. So you can see at the top, the nusinersen, in an antisense fashion, binds to the intronic splice site silencer, thereby allowing the inclusion of exon 7 into the gene. Remember I said there was that single C to G error, and it caused the exclusion. Well, use of nusinersen allowed the inclusion of exon 7, thereby allowing the production of the full-length SMN protein. And before I talk about the results of the clinical trial, it's important to know the natural history. And so this study by Rick Finkel, previously here at University of Colorado and Children's Colorado, was published in 2014. And this was actually published in many ways to set the stage for clinical trials. Right? We need to know what the natural history of a condition is before we know whether or not a drug is going to work. And what this graph on the left shows is that depending on the number of the SMN2 copies, the life expectancy varies pretty significantly. So in all comers with SMA type 1, the infantile form, those non-sitters, the median age to death or ventilation support, and that's greater than 16 hours per day of non-invasive ventilation or trach vent. So that median age to death was. When you looked at the copy number, again, these were all kids diagnosed with type 1. When you looked at copy number, those with 2 copies died at an age of 10.5 months compared to those who had 3 copies. And this is asterisk, the 22 months is asterisk because this study didn't go out far enough to capture all of the children. There were still some alive at the end of this study. So the clinical trial that led the FDA to approve this drug was a really well-designed trial. Remember I said this is injected via lumbar puncture. So instead of doing a lumbar puncture and injecting saline into a child, they did what was called a sham procedure. And so it was a 2-to-1 ratio, so there were about 120 kids, 80 of the kids got the drug, and 40 of the kids got the sham procedure. So what that meant was all kids were taken to the procedure room. All kids prior to being taken had EMLA cream, lidocaine cream, placed on their back. They were taken to the procedure room without any parents, and they either received the drug via lumbar puncture or they received a prick to their back. In any case, each kid had a Band-Aid placed over their back. When the parent pulled the Band-Aid off, the parent saw the prick, maybe a drop of blood. They never knew whether the child had the drug or not. The examiners didn't know whether or not the child had the drug or not. So it was a blinded sham-controlled study. The outcome measures, primary outcome measure was safety, right? This is a new novel drug. They need to make sure it was safe. Event-free survival. And event-free survival for this study looked at, again, greater than 16 hours of non-invasive ventilation for greater than 3 weeks. So in other words, if a child got sick, had a respiratory illness, it was okay if they were on non-invasive ventilation for 24 hours a day, as long as they were going to be able to be weaned off by 3 weeks. So it gave them a little bit of time to recover. But you failed this treatment if you required that non-invasive ventilation longer than 3 weeks. And then looking at motor milestones. So we know infants with spinal muscular atrophy type 1, the time we make the diagnosis is probably the strongest they will ever be. They do not meet milestones like head control, sitting, crawling. And so meeting motor milestones was also something that they were looking at. And you can see the results, actually. I have it on the slide here. You can see the results. They actually stopped this study early because the results were so significant. You can see the motor response. 51% of kids receiving the treatment met the motor milestones. Event-free survival, 61% of those treated versus 32%. This wasn't a perfect drug. There were still children who died with this treatment, but the death rate was higher in those who received the sham control arm. And so the FDA found this compelling enough, and safety was, safety profile was fantastic. The safety events related to common respiratory illnesses associated with this condition or issues around pain in the back, things that you associate with a lumbar puncture. And so it was felt to be safe and effective. Therefore, they stopped the trial, went into an early access program, and then moved right into commercial delivery. Another way to look at it, my mouse working here? You see a mouse up here? No? So you can see in the top graph, it's just another way to display the probability of being event-free and the difference between those who received the treatment in blue versus those who had the sham procedure. And then the bottom one, 22% of the children had full head control, 8% of them were sitting, and then one child was actually standing. Again, those motor milestones may not seem profound, but in the context of a child who has a deterioration in their motor skills, any improvement is impressive. So this first study were infants with type 1. They were, I think, all under 7 months of age. Symptoms had to present before 6 months of age. They went on and looked at other groups of kids. So the study on the left by DeVivo is one that looked at pre-symptomatic infants. So infants who were diagnosed either in a prenatal screen because of a sibling or there was a family history of it in some other way. So they received this treatment within a few weeks of life. And what you can see on the top graph, the blue represents infants who had 2 copies of the SMN2 gene, and the green are 3 copies. So these are kids who could have been type 1 or type 2 based on their genotype. And what you can see is all children were sitting without support at the end of this study, which was at 1 year. And then you can see in the bottom one, walking alone. Walking alone. Infants with type 1 with 2 copies were walking alone. There are 3 triangles at the top, and those were kids who were not yet meeting those milestones at the time that the study ended. But again, very significant. And what you can also see here is that 99th percentile is 99% of kids will meet that milestone by that age. And so these were kids who were not only meeting milestones, they were meeting them when they were supposed to. It wasn't like they were delayed in most cases. So again, incredibly significant results. And on the right, Basil Darris's study looked at kids who were older. So kids who had type 2 or type 3 SMA. I think they were between 3 and 15 years of age, something like that. And you can see the first column are kids with type 2. The Hammersmith functional assessment is a scale, a motor scale that is used in almost all clinical trials now for kids with spinal muscular atrophy. A score of 3 points meets the MCID, or the minimally clinically significant difference. And so the score of 10.8 was significant. Upper limb module, so looking at upper limb function, 4 points. Obviously, they can't participate in a 6-minute walk test. Those with type 3, though, you can see increase over time of 92 meters in a 6-minute walk test. The MCID is, I think, 30 meters, so if you have an increase in 30 meters, that's considered clinically significant, and they had 92 meters. So again, we see it in infants, we see it in pre-symptomatic kids, and we're seeing in older kids. Across the board, these children have benefited. And then the story evolved again. So the pages keep turning in this story, and in May of this past year, the FDA approved the second novel treatment for children with spinal muscular atrophy. Now, nusinersen was approved across the board for FDA. They said all ages, all stages. The FDA approved, and I will say it one time, and only one time, and I may have to ask Anne to say it, anosomnogene abeparvovec. Is that okay? Also known as Zolgensma. They approved it for treatment of kids under age 2, and no one beyond that, at least at this point. So this is gene therapy. So what is gene therapy? This gene is the SMN gene. The full gene is able to be enclosed in or encapsulated in the AAV9 capsid. It's injected via IV one time. This is a self-complementary gene, which means you don't need cell replication to be effective. It is self-complementary, meaning it just continues to produce this protein. It does not get incorporated into the nucleus. It stays extranuclear. So it doesn't get into the nucleus, which is a good thing because we worry about mutagenesis or carcinogenesis. It's a much less of a risk because it never gets into the nucleus. And so it stays extranuclear, again, producing the SMN protein. These are the results, and I don't know if anybody noticed, but this study was published in the same edition of the New England Journal of Medicine as the nusinersen. They did it as kind of back-to-back. The results came out at around the same time, and they wanted to be able to publish them at the same time. They are not a one-to-one study, so we can't say that one is better than the other. They're different. But what you'll see here, and on the left again, is the probability of event-free survival. And event-free survival for this clinical trial, and this was an open-label trial, by the way, the event-free survival for this was greater than 2 weeks of non-invasive ventilation as opposed to the nusinersen. But what you can see is all infants who participated in this trial were event-free. What you can also see on the right side are the motor milestones. And what you can see very quickly as kids gained milestones, and 60 on the CHOP-INTEND, that's an infant scale also used for SMA. What you can see, and it tops out at 60, you can see that these kids hit these milestones very quickly. There was a low-dose cohort. There were 3 kids in the low dose. They did not fare as well, and then one child, you can see in purple, also did not do as well. Stayed stable, but did not make the profound improvements that we saw in the other children. In terms of an update, so this is now an update on those same cohort. There were 15 children, and these are now children with a median age of 27.8 months. 11 of 12 were sitting, half of them were orally feeding, 11 of 12 were speaking, and over half of them did not need any degree of non-invasive ventilation. So again, this has completely transformed the phenotype of these kids with spinal muscular atrophy. So let's talk about the reality of being a clinician in the setting of having these two incredible drugs to deliver, with parents literally knocking on your door, showing up, wanting this treatment, and us having to try to figure out how to do that. There's significant barriers that we'll talk about. Sorry, skipped ahead. Got excited there. As I was putting this talk together and I was thinking about the significant barriers, I just started writing them out. And then I happened to be at a presentation where they used a word cloud. And so here's my word cloud that really reflects a lot of the challenges that we faced over the last 3 years. I'll start with it just randomly. So scoliosis. I talked about nusinersen. It is a lumbar, it's an intrathecal, it's a lumbar puncture. Many children with spinal muscular atrophy type 2 have scoliosis. Some have severe scoliosis. Some have had fusions. So we had to figure out, for these families who wanted to deliver this treatment, how to get an intrathecal injection accomplished. And I should have said it's not one intrathecal injection. This is a series. So when we start the treatment, there's a loading dose, and then once loaded, it's every 4 months thereafter. And to the best of our knowledge right now, it will be thereafter. It will continue until the next best drug comes along. And so in the setting of someone with a fusion, we had to be creative. We opted for transforaminal approaches. We had great interventional radiologists in Seattle who were able to roll up their sleeves and using some CT guidance, were able to do this really successfully, which was great. Other centers did intraventricular. Some placed backlift pumps and then pushed this medicine in through a backlift pump and programmed it. That was interesting. Some did cervical approaches. Some drilled bone windows and did it. So this really required us to think thoughtfully about the risks and the benefits of delivering this in a setting of kids who can be pretty fragile, and we opted for transforaminal. Logistics, this was all about logistics. I have SMA 1, 2, 3, 0, right? So how do we think about prioritizing? So every family was knocking at our door. Every family. So how do you prioritize? Who's going first, second, third, and fourth? So we had to, as a team, sit down, and we brought ethics involved. We brought ethics to the table to help us to understand how we could think about this and how we could deliver this in a fair and equitable way. Expectations were a big one, right? Families saw this as a cure. This was not a cure. These kids still had spinal muscular atrophy, especially if we were treating them at older ages. They were not going to be normal. And so we had to sit down with families and make sure that they knew what we knew. And remember, we only had a couple of years worth of experience. And so it was hard to say exactly how things would turn out. What was the durability of this medicine? We didn't know that. We had no idea whether we would have to redose at some point with gene therapy. You see a lot: resources, insurance, cost, dollar, and 340B. Does anybody know what 340B is? I learned about 340B. So 340B is a federally funded program that delivers any cost drug in the outpatient setting for a lower cost. So medications that are delivered in the outpatient setting can be delivered at a lower cost, and only certain hospitals, children's hospitals, those who take a disproportionate share of lower income also qualify, and there's some other organizations that will qualify but we had to deliver this in the outpatient setting because the only way we could pay for it was through 340B. So cost dollars, no surprise, I'll talk about the expense. So I don't know if anybody knows this top picture. This is Tesla, right? You can see that. This is the most expensive Tesla out there. It's a Series S with all the bells and whistles. Guess how much that costs? 80, a little bit less, someone said 100, $130,000. At least that's what Google told me. $130,000, equivalent to one vial of nusinersen. In the first month, I delivered 4 vials of nusinersen. It was $1 million in the first year, and then every 4 months thereafter. Gene therapy, guess how many Tesla Series S's I could buy? Take a guess. More. Close to 20. It was, I think, 17 or 18 when I calculated it out. The price tag on the gene therapy on a gene is over $2.1 or $2.2 million for one dose. And so, yes, so one dose of that versus 17 or 18 of those. So again, no surprise. There are incredible challenges to delivering this for so many different reasons. So this is how we went about and did it. We pulled a team together. There's a high-cost drug delivery team now at pretty much every children's hospital. And I'm sharing this with you, not to talk just about SMA and nusinersen and Zolgensma, but my hope is that all of you in this room have the opportunity to do what I did, to sit down with this whole team to talk about novel treatments for MS, Parkinson's disease, spinal cord injuries, brain injury, stroke, right? These are high-cost drugs that are just beginning, and we're going to see them more and more in our lifetime. So I'm not going to focus on all of them, but we really did pull a team together. When nusinersen was approved on December 23rd, we had our first meeting of this team in January, which we were probably a year behind everyone else across the country. We were able to deliver, though, because of the commitment of this team, we were able to deliver the first treatment to the first patient in February, 6 weeks after it was approved. The first child received it at Seattle Children's. Pulmonary was critical, right? We have kids who are medically fragile. They're on non-invasive ventilation. An infant who has severe restrictive lung disease, we put them in a flex position to do an LP and they stop breathing, right? That's not good. I talked about ethics already. Governmental affairs, we had to get this paid. We had to go to Medicaid and we had to have someone advocate. So many of us advocated. Ann just advocated 2 weeks ago for another high-cost drug in front of the Medicaid Drug Utilization Review Board. So we all learned how to do this and how to tell the story of these kids and families. The laboratory, so you need to do baseline labs. You need to do follow-up labs. One of the risks, and I didn't share this with you, one of the adverse events for Zolgensma, for gene therapy, is liver failure. There's a black box warning now on that drug because of acute liver failure. There's likely a T-cell mediated response, immune response in the liver because of the capsule itself, not the gene. And there have been a number of reports of kids with liver failure, one almost going to liver transplant, fortunately, has done better. Pharmacy is at the table right at the beginning. I needed to pull in radiologists and procedures to do LPs. Our hospital medicine team now with gene therapy, we deliver it in the hospital. There's all sorts of precautions around how you get rid of the diapers. Like there was a whole meeting on how to get rid of diapers when we deliver gene therapy. So this team is critical. And probably the most critical person, in addition to the hospital administrators who have to approve it, is the coordinator. You need someone to keep everyone moving forward, to keep track of who these kids are, who's been approved, who's not been approved, who needs reapproval, if it's nusinersen. You need someone to tell me when to get labs, when the kid's going to come in for their liver function tests. The coordinator has been instrumental in the safety and the success of these programs. So again, the story just continues to unfold. We have these kids now who are treated. The genotype does not now match the phenotype. And as a rehab physician, it was kind of easy to take care of these kids in many ways because it was pretty straightforward. They followed the same storyline. And now, all of a sudden, they all look different. And so I do believe that we're in uncharted territory. And fortunately, there's an incredible community out there of neuromuscular providers across all disciplines that are trying to figure this out all together. But we're figuring it out as these kids are getting treated. If you're interested in thinking or learning more about this changing phenotype, I refer you to this article, which I thought was really well written. And it talks about some of the reasons why we may be seeing differences in response and also just the responses that we are seeing. So clearly, there's going to be an impact of age when treated. I showed you the data. Infants in the newborn period before a couple of weeks of age look normal when they're treated. The type of SMA, if you have 2 copies versus 3 copies versus 4 copies, you will look different with your treatment. The classic patterns of weakness may look different. These are proximal muscle weakness. That may look different. You know, will your anterior compartment respond differently than your posterior compartment? And I think that Anne and I would say yes. And Joyce and I, in clinic, we deal with these kids who now have powerful hamstrings, and so are developing these incredible knee flexion contractures, which they never had before. We're seeing different responses to bulbar muscles versus axial versus appendicular. We're starting to see, anecdotally, some differences between kids treated with nusinersen versus gene therapy. It may be that various parts of the motor neuron are responding differently. We may see kids who start looking like someone with myasthenia gravis, so profound fatigue instead of weakness. And we still don't know what the optimal therapy interventions are and dosing. And it's actually been interesting. I look forward to maybe Joyce and Anne commenting at the end. But this is a group of kids and families we didn't always prescribe therapy for. Certainly kids with type 1, we were not prescribing a lot of therapy. And kids with type 2 and type 3, we didn't really have a lot of interventions except for kind of adaptive equipment and things like that, but they weren't getting regular therapy. They weren't working on strengthening and things like that. And all of a sudden we're saying, you gotta go to therapy. You gotta do therapy 2 or 3 times a week, and they're a little surprised at that, and it's a little hard to fit it into these kids' busy schedules. They've got music, they've got dance, they've got debate club, they've got all these other activities that they're doing, and therapy may not be a priority for all of them. So for those of you who have been in our neuromuscular clinic, you know it's multidisciplinary, so lots of people asking lots of different questions. So we try to compartmentalize a little bit. And the rehab providers typically will focus on these 4 areas: equipment, orthopedic issues, therapy, and bracing in general terms. So from an orthopedic standpoint, I could hand this over to Dr. Kwok or Dr. Stratton or Dr. Olzak, but historically, we did not follow hips. So this is an image of the hips, an anterior pelvic film, and you can see the big red square. That is a dislocated hip. We didn't follow serial x-rays because we didn't really have a good intervention. In kids with cerebral palsy, we can do osteotomies, put the hips back in, they generally stay in. Historically, when people have tried to put hips back in with SMA, because their profound weakness, they weren't weight-bearing, the hips would just come out, and so we would leave them out. That wasn't great because there were kids who had significant pain, but we did it because we didn't want to put them through an intervention that we felt wasn't going to be successful. We don't know what to do about that now. So we know the natural history in the past, we don't know the natural history in the future. So smart people like Dr. Olzak, Stratton, and Kwok are looking at that prospectively with our orthopedic colleagues. We're looking at spine as well, and we're trying to figure out what's going to happen to the spine in these kids with type 2 who are now standing, or maybe even doing some walking, and how we think about that. Bracing is also very different. So bracing, most kids would have AFOs, ankle-foot orthoses, to maintain range of motion, really more than anything else. The kids with type 2 were not walking. Most of them weren't even standing. They did a lot of sitting, so they developed hip, knee contractures, and so to get them standing just wasn't practical, it wasn't comfortable, and it wasn't part of a family's busy schedule. We're having to rethink that now, right? These are kids who actually have strength, who want to stand or are standing, and so we're starting to write prescriptions now for KAFOs, orthoses that we never really prescribed in the past, we're prescribing now. We're also having to rethink equipment, because equipment is something that in kids with type 1, we rarely ever needed to worry about. Remember, they die by about a year of age. And if they survive because the family opted to do a trach and a ventilator, they were pretty much recumbent. And so we would get them wheelchairs or strollers that just laid fully reclined, and that's how those kids would get around. We would have specialized seating maybe for at home, like a tumble form. We would get a car bed because these infants could not sit upright comfortably, or they would have significant respiratory issues, so we'd get them a car bed so they could recline. This is a picture. I'm going to replay it as I... So this is a child who has type 1 SMA. He was treated beginning at about 3 years of age, and he's now about 6 years of age with nusinersen. He now is able to tolerate sitting up, more upright. He's also able to drive his power wheelchair independently. He's using a small micro joystick. He is still full-time ventilator dependent, using non-invasive ventilation, as you can see here, gastrostomy tube fed. He's got some positioning AFOs that he's wearing on his feet. But we would never have considered ordering a wheelchair for a kid with type 1 in the past. But he gained strength, he gained the ability to sit up, and so we are now thinking about prescribing equipment for kids. And therapy, and this is really an area that is completely uncharted, and we really need a lot of help. We need a lot of collaboration with our therapy colleagues. We have the good fortune to work with Carolyn Kelly and Terry Carey, who have just a wealth of knowledge, really positive information out there on therapy in kids with spinal muscular atrophy. Most of us will refer to this first one. This is actually Dr. Lewitt, as a pediatric rehab physician, was actually at Primary Children's in Salt Lake City for a short period of time. And she worked with Kathy Sabota, who's a big SMA neurologist. And they developed a home exercise program that was delivered over about 12 weeks. And it was really set up as more of a feasibility study. They were not looking at efficacy. It wasn't powered for efficacy. What they found was it was safe, and actually there was a trend towards improvement in strength. And so people look at this to say, maybe we should really think about doing some real strengthening for these kids with SMA. The second study was looking also at resistive training. This was using an arm ergometer, looking at oxidative capacity and function in kids with SMA type 3. And what they found was that there was an improvement in oxidative capacity, VO2 max, but no changes in function for those patients that were participating in that trial. And the third one is really just a study that looked longitudinally over time at a lot of children with different neuromuscular conditions, Duchenne, SMA, myasthenia gravis, and looked at whether or not their time during a 6-minute walk test would change and fatigue. And what this study showed was that kids with SMA don't necessarily decrease their time distance in 6 minutes over the course of a couple of years, but they will actually have greater fatigue at the end of their 6-minute walk test, as opposed to boys with Duchenne dystrophy, as an example, who kind of keep pace throughout that 6 minutes. So I share these with you to say we have a lot of work to do, a lot of work to do. And I'm going to end sort of I started, is the story's changed. I mean, really, I started by saying this is an unbelievable time to be providing care for kids with spinal muscular atrophy. It's a challenging time, right? I knew how the story began, how it was going to end, and sadly, it didn't end well for our infants. But the story's being rewritten, right? We have this ability now to provide 2 novel treatments. There are 2 more that I didn't talk about because they aren't yet FDA approved, but we will hear more about them, one probably in the next couple of months. And so there's so much more for us to learn, so much more for us to offer, so much more for us to collaborate with our colleagues across all the different disciplines. And I'll end by saying, I hope for you, really, especially the residents and fellows, that you have an opportunity to be able to experience what I've been able to experience in 20 years, which is a completely different story. What I thought I knew is completely changed now, and the incredible privilege it is to be able to care for these kids and these families. It's just really quite remarkable. So I hope for all of you that you have this sort of novel treatment, this nusinersen, Spinraza, Zolgensma experience as I have had and others in this room have had. So I will end there, and I'm happy. It's a great question. So the question, for those who might be listening, is around how do we talk to families about the different treatments. So there are 2 treatments now, so we can start with that. There's the nusinersen, so it's an LP, and then there's the gene therapy. I'll start by talking about the newborns, because that's right now, I think most of us have a little bit of a clearer picture. One, it is always a family choice, and so it is our job to talk about what we know, what we don't know, and then to talk about what these interventions are, how they work. Because we are now, Colorado and Wyoming are part of the newborn screen, SMA is part of the newborn screen in Colorado and Wyoming, and we at Children's Colorado actually are responsible for getting those results of those newborn screens and bringing kids and families in immediately, the day after they're born or the day after we get those results, to start these conversations. I think the general feeling in the community for newborns is to go with gene therapy. And the reason, I can just speak for myself, I think that it is the fact that it's a one-time intervention is very appealing. It's scary and because of the potential risk, and we have had the experience of having a child in liver failure, and it is scary to be part of that experience. But we believe that that the durability is going to be good, and the fact that it is a one-time treatment is probably a better option. And that's been, I've met with 2 families. I've had the privilege to meet 2 families of newborns born in the last 3 months, and both actually ultimately opted not to treat. And one of the infants died on Monday at home, which is what the family wanted. We were able to provide palliative care services. And so they really were very comfortable, as were we, with their decision. And the other family also opted not to treat, and that infant is still alive in Wyoming. But both of them talked about the difficulty with making the decision ultimately. But when they were thinking about treatment, they both thought about the gene therapy because of the fact that it was one-time intervention. And neither family could even bear to think about putting their newborn through lumbar punctures. And so that's the decision they made. In terms of older children, so we have some limitations right now. Gene therapy is only approved for those under 2 years of age. So once you hit that magic 2-year mark, we don't have the opportunity to really offer it to another family. We've had families ask for it, but we can't deliver it because an insurance company will not pay for it. And so those children have access to nusinersen. For those older kids that are making some decisions, so there's a young woman who is now well into her 20s. I cared for her when she was little, and her brother when he was little. Now they're in their 20s. She initially started nusinersen treatments via lumbar puncture. She had a lot of complications from the LPs, so she stopped. She didn't feel like she was making any progress. She stopped, and because now there's actually expanded access for something called risdiplam, which is an oral ASO, oral antisense oligonucleotide. She's opting for that. So I wonder, actually, as soon as that's approved, it has to be approved by May, whether or not we're going to have some families opt to switch from nusinersen to this oral agent. Again, those older children won't be eligible for the gene therapy just because of the restrictions. Other questions? Yeah. Yeah. So the question was about dual therapy. And there are a couple of families who had children who were under 2 years of age, so started in the newborn period with nusinersen because gene therapy wasn't available. And as soon as it became available and they were still under 2, they wanted that treatment. And we have two families that wanted the gene therapy. And so we have asked for approval, and we got approval in 2 cases and delivered it. I think the question will come up if they got their gene therapy, if they want to now flip back to nusinersen. I don't know, Ann, and Joyce, are they getting the nusinersen? Good. And insurance companies, I think, are going to be dictating some of that. So we got Wyoming Medicaid to approve gene therapy for this newborn who picked up a newborn screen a couple months ago. And I had a conversation with the Medicaid folks, and they made it very clear that this was the only treatment that they were going to be providing. That if this family wanted, after gene therapy was delivered, to start nusinersen, they would never approve it. I get it. I think we will learn more about this dual therapy. The child who had liver failure had dual therapy. The question is, was dual therapy putting that child at greater risk for having that complication? There's a lot of unknowns. I look at these families. I mean, think about, you are a newborn parent, right? You just get home from the nursery, and your pediatrician calls you and says, we just got results that say your child has something called spinal muscular atrophy. We need you to be seen tomorrow to talk about this. And then I show up and I start talking about this treatment. I mean, these are new parents. In the last case, the last little boy, the child who passed away on Monday, they had a son 15 years earlier who had spinal muscular atrophy and died as a 6-week-old. So they knew. The other family, I really, when you talk about informed consent, there was not a whole lot of informed consent there. There's no way these families really, truly understood what we were proposing in terms of short-term and long-term complications. Other questions? Dana, you had a question? In terms of intrathecal versus IV? Yeah, I think intrathecal. And there's actually, I think that, the motor neurons, you want them to get to the brainstem and the spinal cord. And so I think intrathecal, there is going to be a trial with the gene therapy. Actually, it's started, a trial with gene therapy that's going to be intrathecally delivered. Yeah. It crosses the blood-brain barrier. The AAV9 vector crosses the blood-brain barrier. But the question is, if you can bypass that altogether, can you get better delivery? Yes. I don't believe so. I'm looking at people who may have had routine screens. I don't think so, but it is now recommended as part. ACOG recommends it. So when women go in and they talk about different screening tests, it's a carrier. The mother's just getting tested to be a carrier, and then you can test with amnio to see if the child's affected. But you're looking at carrier testing, and if the mother's a carrier, then you test the father to see if they're affected. It's not 100%. There's some weird ways that glitchiness that actually allows you to test negative. I had a dad that tested negative, but you can actually have 2 copies of the SMN2 gene on one chromosome, which is what he had. SMN1 gene on one chromosome. They looked at the other one and it was negative, so, or they count the number of copies and they saw the 2 without knowing there was actually one with none on there. So, yeah. And so they had a baby. Yes, Lisa. I would expect them to decline. Yeah. Because it's a, go ahead, Ann. Yeah. I mean, this does, as opposed to gene therapy, which is you're continuously, they had the CMV promoter on the gene. It's a chicken promoter. It's crazy. That helps it continuously just produces the SMN protein. But that's different than the ASO, which is really, there's a half-life, and it wears off, and so you have to redose it. Yeah. I bet. Other questions or comments, Joyce, Ann? A chicken promoter? So they put all sorts of cool parts on to the gene, to the vector, so that it gets to the right tissue. So I'm involved with a gene therapy trial for boys with Duchenne dystrophy, and so they're using a promoter that gets into the heart muscle, right? Because you can want it to get into skeletal muscle. That's a given, but you don't want kids who are strong but still have cardiomyopathy, and so they have these promoters that get into the heart, which is pretty cool. Oh, now you want to know chicken? I don't know. I don't know why chicken. I don't know. You got me there. So, all right. Well, maybe we'll end with that one. So, thanks.